Okay, so I don't think I have much time left for two lectures, and one lecture also would be a little tough to finish. So we'll try to go a little faster. My gratitude, and how can we forget this gentleman? Because of him, all these our lamellar keratoplasty, whether DLK, DSEC, Desmet stripping, DMAC, whatever we say, it's thanks to this gentleman. We know we earlier started with PKP, and then we started with lamellar keratoplasty, where donor and recipient both had to dissected manually. We then reverted to donor being dissected manually and the recipient just Desmet stripping, and then we have both of them done automatically, or rather Desmet stripping and donor being prepared automatically. Obviously the endothelial keratoplasty is better than PKP because it's a closed chamber technique, has less chance of rejection, visual recovery is much faster. The cases which are best reserved for such technique is where you have more potential of vision, where you don't have scar in the visual axis in the cornea, and which is like pseudophakic bullous keratopathy or Fuchs endothelial dystrophy or previous failed graft. My preferred technique is DS-AEK, where I use an automated microkeratome to prepare the donor button. The donor button, I use a Moria system to prepare the donor button, where the cornea is mounted on artificial anterior chamber, and using a turbine and turbine based microkeratome, we cut anterior 300 to 350 micron of the cornea, and the rest cornea is punched out into my preferred diameter is 8.5 millimeter. Well, this is a video, but I think we'll just in the interest of time we'll go ahead with the surgery rather than the donor preparation. Now, after you punch out the cornea of donor of the desired size, which I use 8.5 millimeter, you pay your attention to the recipient. The recipient first, as Dr. Yati showed earlier, first we have to do a Desmet scoring, and we remove the Desmet membrane along with the endothelium. Here I put a corneal incision a little larger because I had to remove an ACIOL, which was a little smaller in size, and then I'm doing a desmetorexis, and I'm removing the Desmet membrane. Once the Desmet membrane is removed, then your recipient is ready. Now, a lot of people use different technique. You can use viscoelastic to do this test. If you use viscoelastic, make sure you use a cohesive viscoelastic and clean it off totally so that there's nothing in between the graft and the recipient. Once you clean it off, then you pay attention to your donor button, where your donor button, you have different techniques of inserting your donor button inside inside the anterior chamber. People use sheet glide. You can use Stacco technique. Now this one, you might be surprised what I'm doing. Well, this is actually femtosecond laser assisted DSEC. So I dissected that tissue on femtosecond laser. Hence, I don't have any marking on the stromal side. I'm putting marks. I'm putting like 2 dots on one side and next to it 1 dot. I use tan endoglide to deliver my tissue, and I'm loading my tissue into the tan endoglide. And then you insert the back part, which prevents the tissue to slip out. You flip the tissue, and you make a incision into the opposite side, and you just pull in the tissue. Do not leave the tissue at this point of time. Continue your AC maintainer flow. Let the tissue come inside, then leave the tissue. Stop the AC maintainer. Put a suture onto the wound. You can adjust your tissue there, and then increase the amount of air which you have. You can use stroking technique, or I use Lindstrom roller to squeeze out the water in between the interface and the donor tissue. And later on, after 15 minutes, we would like to reduce the intraocular pressure by reducing some amount of air. You can also use Busin glide, but I personally don't have much of liking towards Busin glide. You can combine a lot of techniques with the DSEC. You can have vitrectomy, you can have phaco, you can have anti-glaucoma surgery. Finally, what's important to remember is that end of the, and see here there are markings of the stroma on the stromal side. The loading would probably remain the same. Post-operatively, well, we can have our own complication. You can have dislocation of disc, which is the initially most common, especially in initial period of your career, you might have more dislocation. That's mainly because of more handling of your tissue rather than anything else. But later on, with most of the series does show that initial period, whatever dislocation rate, later on they do come back to a really normal level. Primary graft failure again would also depend on how much manipulation you do with the tissue or how good quality tissue was. You can have more chance of glaucoma. Rejection is much lesser than PKP. The latest one is descent membrane endothelial keratoplasty. Why do you have stroma? Why do you need stroma? I mean, stroma, when you put it reduces the quality of vision. So instead of keeping the stroma, why don't we just transplant descent membrane along with the endothelium? And that's where Gerard Millis brought out this technique of descent membrane endothelial keratoplasty. There are different ways you can dissect the descent membrane. The most important, or I would rather say the two common methods of removing descent membrane is one scuba technique, where you keep your MK medium, and under the MK medium you peel off the descent membrane. Good part, this technique works wonderfully well when you have a little adult tissue where the peeling off is easier. Bad part, when you have a young tissue, well, this does not help too much. But if you have younger tissue, probably you can do a big bubble technique or something which is recognized now as PDAC technique. So, talking about the donor preparation, well, donor preparation, as I said, this one is the DMAX, so scuba technique. So, under the MK medium, you peel off the graft from the periphery, making sure you do not touch the center part, and then I'm staining the endothelium, and then I'm punching my desired size, which is 8.5 millimeter. Again, I would stain the endothelium, and that's when my graft is ready. The same thing can also be done using PDAC, as in the posterior dissection using the air bubble. You can inject the air bubble posteriorly, trying to keep a little more superficial towards the back side, and keep injecting, and there you get a big bubble there. You can enlarge the bubble. Please remember, this is type 1 bubble. You do not want to enlarge too much, otherwise it can burst. I'll show you some of the video of that also. So once this is ready, you go ahead and just open up the bubble, stain it on both sides, inside as well as outside, with the trypan blue, because the worst thing you can ever do in DMAC is less staining of the donor tissue, because when it goes inside, sometimes it's really impossible to locate your tissue, and the worst thing is you have tissue inside and you don't know where it is. So it's always better to overstain the tissue rather than understaining. Now what happens if we try to inject the bubble and we still don't get big bubble? Well, you can do another things, like you can use viscoelastic. As you can see in this case, I inject the bubble and I got stromal emphysema and it didn't get bubble, and I switched over to viscoelastic, and as you can see here, my small tiny bubble starts appearing, which I can enlarge with either saline or viscoelastic itself, or I can use air also. The only disadvantage here in viscoelastic dissection is sometimes it's a little difficult to get rid of that viscoelastic which is there on the back surface. Now, lately I would start using MK medium for this thing, and this works even wonderfully well. So you have an emphysema, you don't have big bubble, you go ahead with MK medium inside and inject the MK medium. Now this is where I'm going with the MK medium, and you start injecting, and you have the big bubble coming up then. The same bubble. Now, a very interesting thing I would like to show here. I've been talking about this thing, but I became greedy here, and I said, let me make it a little bigger, let me make it bigger. This was good enough. I didn't have to do anything. But I became greedy, and I started enlarging this bubble. Now see what happens. You have double bubble here. You have the burst of Dua's layer, and this came between Dua's layer and descent membrane. However, it's still fine. I mean, we can still go ahead and do the surgery. It doesn't matter. So same way now for the surgery. The surgery, the donor preparation is same as what we did for DSEC. So I'll just forward the donor part a little bit, where the desmet stripping is done. And I always prefer to make an inferior PI with all my DMAX. And in fact, all D6 also nowadays, I put an inferior PI. I've just become a habit of that. I use simple IOL injector of butterfly style. The trick here is you put the tissue inside, put your BSS inside, and close the front part. I don't remove spring. A lot of people like Price and those people say that you remove the spring so that it does not come inside. Well, it does happen. It did happen almost one time where when you release the spring, it can actually suck back the entire complex. Well, so be a little more careful about that. And if you want, you can remove the spring from the donor. Well, we'll just try to do a little fast forward if I can. So finally, once it's inside, then small jets of, and that's where the kusti starts. That's where you have to keep injecting small spurt of saline, which probably helps you to unfold the tissue. Once the tissue starts unfolding, then you start. So what I do is I like to put a bubble on top of it so that I put it on the iris then. So entire tissue then opens up. Once entire tissue opens up, then I put one more bubble below that and remove the previous bubble which is over this thing. Once you put the bubble on top of it, well, your surgery is pretty much over. Sometimes it does take, last surgery, it took me half an hour just to unfold the tissue because it has a mind of its own. A lot of time the problem occurs, we don't know which side it's opening up. There are certain clues which you can follow. What I like is something what Melis says, Venn diagram technique, where you have the tissue which is normally rolled up. If it is rolled up on the wrong side, I think we can discuss this thing one-to-one later on, otherwise we'll not be able to finish the lecture. So if you become too much greedy, this is what happens. Now I am injecting air here and I'm getting nice bubble, and please remember type 2 bubble, and I keep on injecting. I should have stopped it, and then what you get is a burst bubble. Well, that burst bubble you cannot manage, that's done. You also can have hybrid technique where people have used a big bubble and then put a keep a small skirt of donor cornea also there. So you have DSEC as well as DMAC, both of them. The tissue behaves like DMAC, but you have the handling of DSEC. So that's it. I don't have any personal experience with this thing, but sounds interesting. But I'm sure the peripheral part which is standing out can be a sore thumb sometime. The future would be in vivo culture of the cells, which Azar and his colleagues have been trying in Massa and Year. The transplantation of cultured limbal stem cells, or rather I would say stem cells, which can be injected into the anterior chamber, can be the future, where the homing would take the cells wherever they should supposed to go. And if they are autologous, well, nothing better can be than that. So to conclude, endothelial keratoplasty, an excellent alternative to PKP in case of endothelial disease. DSEC is a promising and minimally invasive technique. DMAC is an extremely promising technique. However, the refinement and the surgical technique as well as the donor incision is required, and that would be the future. Thank you very much.